let's start from here. So we were doing some of the infectious disease. We did fever, we did otitis media with diffusion, and this one. As you can see in my notes, whatever I'm telling in the class, it's basically there. Okay. So those are the just the important points that I'm telling you in the class. I'm just reading overall and telling you the important points. In the notes is just the important points written there, not other things. But those are not just enough for you, okay? I think we already discussed these ones, rheumatic fever, meningitis, the medication for meningitis, then we did the mumps. Now we are going to do the pertussis. The pertussis is important because this can be asked in the diagnosis and can be asked what is the gold standard test for that one. So the gold standard is anti-specimen and using aspirate in that cases and then going for PCR or CBC. So usually they are looking for this word. Gold standard is culture using special media. And this can be written in the MCQs, the Reagan, Lowe, Agar. Sometimes and sometimes not written. So you still need to keep in the mind what is the special media. In that case, is what happened is admit if the paroxysm of the cough and causing cyanosis, choking, in that feeling, sportive treatment is there. Antimicrobials can be given indicated if the beta pertussis. And in those cases, they will mention the immunization criteria for sure and the prophylaxis to the household. Then the sinusitis is one of the very common presentation, especially for with the upper respiratory tract. Usually you have to ask about the previous history of upper respiratory tract. So these children may have a history of over the time upper respiratory tract again and infection again and again. Diagnostic imaging is not required, but people do insist on getting CT scan. So you can go for CT scan, but CT scan is not recommended anyway. Then the treatment is amoxicillin, which is basically given within 4 weeks. So how do you decide this is sinusitis, not upper respiratory tract infection? Usually they have pain around the sinuses. So complications could be preseptal cellulitis or orbital cellulitis, then osteomyelitis, intracranial infection, port puffy tumor is one of the most common presentation. They can give you a picture and then can be asked which kind of infection can causes. So sinusitis is one of the most common. And in those cases, you have to give the IV antibiotics. So you can see the port puffy tumor, they have given everything. Standard soft tissue, erythematous swelling on the forehead. What does it cause? Headache, photophobia, fever, and IV antibiotics should be given in that cases. Then comes the UTI. We already discussed this one. It's very, 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 very important, especially in the females and in the males as well, but in females is very, very common. So always think of in the fever cases, go for UTI. So you can see the pyelonephritis, fever, pain, and then CVA. It's just how you assess the patient with the fever, you have to do the same thing. So in the cases who are just less than 2 months, you have to admit them. I think we already discussed this one. We already did the neonatology too. Then apnea, we were already discussing how you have to do the apnea. So stimulation and then going for the other one. Which stimulation? Tactile stimulation. Then the bleeding disorder. This one is also being done. Bronchopulmonary dysplasia. I think we're here. We did this one too. Sorry. So we are going to do the cyanosis. Okay. So cyanosis, all you need to know the diagnosis, okay, especially in cyanosis. And the treatment is basically elevated CO2 suggested the respiratory cause. So in that cases, you do the hyperoxia test and giving the oxygen. So you can see how you check for the ABGs, elevated CO2 and hyperoxia test. So think of this hyperoxia test whenever they're talking about neonatology and talking about cyanosis. If they ask for the test, so this is the one they're looking for to distinguish between the cardiac and respiratory causes of the cyanosis. So here you can see it's a peripheral or the central. Peripheral is like basically on the peripheries. So it could be transient, maybe with a cold temperature or like crying, could be anything. Then this is basically sepsis. Then the other one is central. Central is divided into hyperoxia test to checking for deoxygenated blood and then abnormal hemoglobin. Abnormal go for carboxy, methemoglobin, could be anything. Then the deoxygenated, in that one checking for respiratory and cardiovascular, we go for hyperoxia test. So respiratory, we already know which one can cause, like wherever the breathing issue, lung issue, all of that, pneumothorax, hypoplasia, pneumonia, all of that. Then the cardiovascular, we already know which one, teratology of Fallot can cause it, PPHN can cause it, all of this. Then neurological. Why this can be asked? Because, it's very less likely you think that sears can cause cyanosis. So they can ask you. And then opioids exposure, like, a mother was taking some medicine, she's using it for pain, and now the child got exposed to it. Now he's having cyanosis. So they are looking for that particular drug, right? Just knowing that, mother drug abuse is not enough. You need to know which drugs causes cyanosis in the kids. So opioids and sedatives are the one. Then in hematological, polycythemia causes it. Sepsis is one of the most important that causes central and peripheral. So if you forget about anything in cyanosis and they ask for differential diagnosis, so you can go for sepsis. Then the diaphragmatic hernia, why is it important? Because they give you a X-ray where the lungs are in the abdomen. So, or like the diaphragmatic hernia, like where the loops went up ahead. So in that case, is what happened is the diaphragm between is basically collapsed. So either the structures from the top went down or the structures from the down went up. So it could be in any way. So developmental defect of the diaphragm, so herniation of the abdominal organs into the thorax. So in this case is respiratory distress. Cyanosis is one of the most common, and then you can see this word they're talking about the chest x-ray for the diagnosis. So mainly we do the chest x-ray for the diagnosis. Then they said the scaphoid abdomen is there, barrel shaped chest, so they can give you a picture. It's a very high yield question, the x-ray, and figuring out what's going on inside. Okay, because most of the time the picture is so like not that crazy nice, so you can able to tell. So it's better to see the clinical features. At least you are able to find out from the clinical features what's going on. But if you are a very good person who can see x-rays, so in that case is definitely you can look for that. Then what are you looking for? The bowel loops in the thorax and displaced mediastinum. So immediate intubation should be required. Do not go for the bag mask because it just only can increase the air in the whole cavity. Then the large bore orogastric tube to decompress the bowel. So which tube you are putting, not the nasogastric. Here you have to go for the orogastric. Please keep it in your mind. Initial stabilization and then treatment. So the word they are looking for is intubation and the orogastric tube. Because the contraindication is already written here. Do not use the bag mask ventilation. So they can ask you this one. Then comes the hypoglycemia. I said whenever a newborn baby, they talk about it, hypocalcemia, hypoglycemia. You have to keep that in your mind. Whatever is going on may be caused by this. Neonatology means the person, baby, who just born within 72 hours or within 3 days, something like this. Okay. Any kind of presentation, if you don't like, unable to make any kind of diagnosis, just at least think of hypoglycemia. It can save you many times. I'm not saying all the time, but many times. So then they say sepsis, hypothermia, polycythemia, and perinatal stresses could be there. So identify and monitor the risk at least 12 hours. So mainly the diabetic females. Although it feels like diabetic females should have a diabetic kid, but diabetic females mainly have a hypoglycemic episodes in the babies. In a well at risk infant, being oral feeds as soon as possible. So you can start the oral feeds right away at birth and ensure the regular feeds. If significant or symptomatic hypoglycemia, in those cases, give IV. And if persistent hypoglycemia, then prolong the glucose intake. Then you can see ABGs, ammonia, oxybutyrate. So we are checking for everything else. Then comes the neonatal hyperbilirubinemia, one of the most common thing that's being asked here is connectures. Okay. Then it's basically unconjugated, conjugated. I mean, this table, I could never memorize this table. I don't know, something is wrong with me or something, but many things asked from this table could be asked a pathological. If it's a pathological, if it's a physiological, what is the jaundice going on, whatever. I always like keep mixing up things. So it's better if you guys look into this one. It's an unconjugated and then conjugated. Conjugated is always pathological. So what I mix is basically, I think that pathological is unconjugated. So unconjugated could be pathological and physiological. But when it comes to conjugated, then always pathological. So think of CP child. So think of CP, conjugated pathological. Okay. And in pathological could be, we know jaundice comes from hepatic and post-hepatic. So we are talking about here what are the hepatic causes? Mainly hepatic includes infection, a metabolic problem. So always, I'm just telling you this one too. We will do another thing from neonatology where we are talking about galactosemia and stuff. This is another chapter. So always think that galactosemia, tyrosine, antitrypsin, these are ones that affects the liver. Okay, that's why the digestion got the problem. Hypothyroidism, cystic fibrosis, these are the ones that drugs can cause it. TPN and neonatal hepatitis. Post-hepatic is after the liver. What are their gallbladder, so choledochocystal biliary atresia. So biliary atresia, those are the things that can be caused. Unconjugated, mainly what they like to ask is physiological, because in that cases you have to do the reassurance. And you have to be very confident when you are doing reassurance. But at the same time, if you do a reassurance to a person who is pathological, then it's dangerous. So it's important that you are confident when you are saying no, but at the same time, you have to be very like you are saying no for antibiotics to someone, but at the same time, you have to make sure that this person 100% does not need antibiotics. Imagine if he came later on with very, very worsen of situation, but you can always justify yourself from your notes, like usually what we do, by like at that time he was not having this, that's why I did not give antibiotics. So it does make sense. Then pathological, it's hemolytic and non-hemolytic. Hemolytic is all the blood, whatever things going on. Non-hemolytics is mainly sepsis, hypothyroidism, Gilbert, Crigler-Najjar, hematoma. So at least if you are not going through any of them, at least go through Gilbert syndrome. Okay. Then the jaundice is very common. 60% newborns do have a visible jaundice. Jaundice is like to love first 24 hours. Within first 24 hours is conjugated. And it's always pathological. After 24 hours, you can think of physiological. Jaundice may be investigated if it occurs within 24 hours. If it's a unconjugated bilirubin rises rapidly. So it's like with the age you were thinking, and it just whole body turned yellow, eyes yellow, everything yellow. Now you are thinking of what's going on. And then the weight and age is also like problematic. So it start making sense to you, like, how a toxic looking and non-toxic looking child is. So age, weight, bilirubinemia, all of that can be like in that cases you have to investigate. Persistent jaundice lasts beyond 1 to 2 weeks of the age. Then the physiological jaundice, one of the most important question and most exam favorite. What is that one? So in this one, you need to know that 3 to 4 day of the life. It starts like not within 24 hours. Resolution within 10 days of the life. Premature infants, higher peak and the longer duration. So in this one, what happened is hematocrit is increased and RBC lifespan decrease. That's how they got the jaundice. Then what is this GGT, the glucuronide transferase enzyme increase intrahepatic, all of this one. Then the breastfeeding jaundice. So they do like to ask you about the breastfeeding and breast milk. And then in that exam, I'm 100% sure if they ask something from here, they will give you breastfeeding, breast milk, physiological. They will not put something like, they will like to check if you are able to differentiate between breastfeeding or breast milk. In that case, they might give you only one or two things where you are able to differentiate. So breastfeeding, due to lack of the milk production, dehydration and exaggerated physiological jaundice. So this is basically due to lack of milk production. So it's mainly the dehydration. So a main thing that you are looking for in breastfeeding is dehydration. They will tell you sunken fontanelle, the baby is not peeing a lot. When he's crying, there is no tears. And then he's not taking enough milk, and all the neglection could be there. So this will give you an idea that this is breastfeeding jaundice. Or a neglected child come to you with jaundice, so in that case you can think of breastfeeding, because neglection, dehydration, everything start making sense. Then the breast milk jaundice is basically, although this is lack of milk production, but I'm talking about in the other point of view. They can be presented by a mother where she's trying to breast milk, give the breast milk, and now she's having dehydration and now the jaundice is there. The mother can present. In that case, you can think that the mother is not very interested and you feel that this is a child neglect. Then in that case, you can check for dehydration. There's jaundice, then this is breastfeeding jaundice. So can be presented in both ways. Then the breast milk is basically there is some glucuronide transferase inhibitor, onset of 7 day of the life, so it's usually after that. So today we checked for a patient for jaundice, just giving you an idea. The baby was 15 years of the age, and she was presenting with jaundice, like a very high level jaundice. So we checked for the glucuronide transferase inhibitors because we were thinking that he might have this breast milk jaundice. Although it's a thing of pediatrician, but we are a family physician, need to know this much level. So after this, now it came out positive. Now she has been lacking of this glucuronide transferase. So if we try to manage, we can do it. But if it's you feel like you are not able to manage, in that case, you can refer the baby to the pediatrician. And many cases, baby do have pediatrician, but they're not following up with them. Onset 7 age of the life, peak at 2 to 3 weeks of the life, casually usually resolved by 6 weeks. So it usually resolves by itself 6 weeks. Maternal factors, perinatal factors, and neonatal factors. What could be the causes? So you can see ethnic complications, breastfeeding, and then public, and then birth trauma like cephalhematoma. It's a very, 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 very important thing because they can give you a picture of cephalhematoma, or they can ask you this was trauma on her head when she got birth, and now she is having jaundice. So in that case, all you have to do is reassurance. So the word they're looking for is reassurance. Okay. Then ecchymosis, because in the child abuse could be there. So in that cases, you always have to think of child abuse as well. Then comes the prematurity and difficulty establishing breastfeeding. Then the infection, genetic factor, polycythemia, drugs, and TPN. Causes of neonatal jaundice by the age. In that cases, you need to know by the age. If it's less than 24, always think of conjugated and it's pathological. We already discussed this one. Hemolytic, blood-borne diseases, sepsis, congenital infection like torch. When it comes to torch, there is something that is something. I don't know if it comes to my mind, I will let you know. Swear, bruising, and hemorrhage. Then 24 to 72 hours physiological polycythemia, dehydration, hemolysis, G6PD deficiency, one of the very common one. Pyruvate, spherocytosis, bruising, hemorrhage, hematoma, and sepsis. Then 72 to 96 is this is basically physiological and breastfeeding. So mainly the sepsis. In the cases of 72 to 96, mainly if there is no fever and no indication of sepsis, we just do the reassurance. But there is fever and all that, then look for sepsis. Then the prolonged one, breast milk could be there, prolonged physiological jaundice, hypothyroidism, but you have to do all the investigations. Gilbert, Crigler-Najjar, inborn errors of the disease, and biliary tract obstruction. Then comes the pathological, mainly unconjugated, but some cases could be unconjugated. Then conjugated hyperbilirubinemia, you have to do everything CBC because we are looking for all the tests, and then reticulocyte, Coombs test, checking for high hemolytic diseases. If baby is unwell and fever, as I tell you, you need to go for septic workup and then check for the G6PD. Then this says in which cases, especially in the males. Okay, so the word is male. Although I saw today a patient with a female, but usually it's a male. TSH, thyroid is one of the most common. As I said, you know how you are thinking of neonatology about hypoglycemia and hypocalcemia. Just keep that in your mind. Sometimes some things, like not some things, many things are linked with hypothyroidism as well. As you see, if you go to the picture of hypothyroidism, baby, congenital hypothyroidism, there is many things that is like linked with many of the diseases. So if you are not sure of anything, you can always think of your differential as an hypothyroidism to congenital hypothyroidism. Then conjugated hyperbilirubinemia must be investigated without delay. So checking for the liver enzymes, PTA, PTT, serum albumin. Then what else is there is basically ammonia, TSH, torch, septic workup, galactosemia, checking for all of that, ultrasound, HIDA scan, sweat chloride for cystic fibrosis and everything. Then pre-occurrence of the measure either total serum bilirubin level or the transcutaneous bilirubin concentration in all infants between the 24 to 72 hours. So here is something about, you need to know the difference between unconjugated and conjugated in blood work. Like what is the difference of bilirubin in that one? So it's kind of different. Okay. So just look into that one. And it's an important question. I don't know if it's given here. We'll see. If not, then at least do a little bit of research. What is the bilirubin? blood work, or the what is the blood work of unconjugated and conjugated? Like, how do you tell the difference? If infant does not require immediate treatment, results should be plotted on the predictive mammogram. Then we are talking about here treatment of unconjugated hyperbilirubinemia. To prevent, they can ask you directly, what are you trying to prevent in unconjugated hyperbilirubinemia? Or they can ask you a question where they give you a scenario which is leading towards whatever it is and ask you what could be the complication. So main thing is conjectures. Breastfeeding does not usually need to be discontinued. So many things, most important things. So they said, what will you focus on your counseling? So in for counseling part, we will focus that you have to continue your breastfeeding. Ensure adequate feed and hydration because it could be the breastfeed. Then the lactation consultant support mothers to pump after the feed. Treat underlying causes is basically sepsis. Phototherapy, usually we go for phototherapy. Even if some children does not, like mothers are not comfortable because of the eye damage. That's very, very common thing. So you have to tell them we use eye shield and all that, but you can always tell them you can do it under the sun and all that. Skin rash, diarrhea, dehydration is one of the most common with the this one. So they can ask you the phototherapy. It's actually safe, but what are the complications or what are the side effects of it? Then the serum bilirubin should be monitored during and immediate after the therapy, and it should be placed and then risk of the rebound because the photoisomerization is reversible. Contraindicated in conjugated, so you have to make sure the phototherapy is only done in unconjugated. That's why they can give you a blood test, like giving you serum albumin or whatever it is, and from that blood work, you have to tell it's a conjugated and unconjugated, and then you have to tell if what is the treatment. Although it's like a kind of long question, like a very 5 to 7 line question, and then you are reading and you're not making sense to you, but then suddenly they ask you what's the treatment you will do. So what you need to do is like which one is conjugated and unconjugated. Unconjugated, go for phototherapy. If it's like conjugated, then it's a different treatment. So what do you and where do you plot the bilirubin? Serum bilirubin, it's a nomogram. Okay. If total serum is above cut for the respective gestational age. Then comes the exchange transfusion in those cases where you feel like high bilirubin as per published per chart, most common performed for hemolytic G6PD. So, where there's bleeding and something ongoing, in those cases, you have to do the exchange transfusion. IVIG and SWER, hyperbilirubinemia should be done. So think of hemolytic one, okay? Then think of a bronze baby. They can give you a picture of bronze baby and ask you to make the diagnosis. In those cases, this is basically conjugated. Phototherapy is in the production and accumulation of the toxic metabolite and can also impart a bronze baby due to on the baby's skin. So it can become on the baby's skin. So, again, this one is something I would say at least see the serum bilirubin level. I'm not sure exactly what the question is. It's not coming into my mind, but something related to this total serum bilirubin. Then comes the conjectures. The unconjugated bilirubin concentration exceeds albumin binding capacity and bilirubin. So in those cases, it just binds to your brain, not to your brain, but to the child brain. So low levels is the sepsis, meningitis, hemolysis, hypoxia, acidosis, hypothermia, hypoglycemia, and prematurity. Then early stage is basically hypotonia, mid stage is hypertonia, and then late stage is hypotonia. So they can ask you this question too, like which stage it is and what is your goal of treatment. So early stage is basically acute bilirubin encephalopathy. You can treat it and then it can get better. But when it comes to mid and then late stage, it's hardly to bring the child back to its normal stage. Then the bilirubin, biliary atresia. Atresia is basically in this case, the most important is dark urine and the pale stool with jaundice. So simple three things will make you biliary atresia. Usually the thing that you do is HIDA scan. This is the timing of diagnosis is critical. Then usually we go for surgical drainage. Then the most important thing, the vitamin A, D, E, and K enriched diet should be enriched with the medium chain triglyceride to ensure the adequate fat ingestion. So they can ask you fat or which vitamins you would like to add. So usually in the scenario, they don't say A, D, E, K. They ask for which one. So these are fat soluble vitamins. So A, D, E, K. Or they can ask you fat soluble vitamins or which one, A, D, E, K. Then comes the necrotizing enterocolitis. Again, when you are talking about neonatology, please see the pictures. How does they look like? And like just now we talk about connectures. So we see how does the connecture baby look like. Then we talk about bronze baby. Then now we are talking about necrotizing enterocolitis. So, and then we already talked about diaphragmatic hernia. Pictures are very, very, very important. Like, I don't know if you guys will get the pictures or not, but they do like to ask a lot of pictures. Then prematurity, asphyxia, shock, hyperosmolar feeds, and enteral feeding with the formula or the sepsis. In this case, a mother can present mainly the children are homeless, child neglection, or like poverty. Like, they are not having enough meal or homeless kind of thing. Why? Because they are making the meals differently. That's why they're making hyperosmolar. So they will give you an idea about like either the problem is the milk or either they are uneducated, either they will say they are refugees. So you can get an idea that they are not aware of what they are doing. Okay. Or maybe a child neglection where they're trying to save the milk. So all these things can make you think that this is basically coming from hyperosmolar. So that's what I'm saying. These refugees, indigenous, immigrants, like these kind of things are very, very common in many, many of the diseases. So you have to think of every perspective when they are using these words. They're giving you hint of some sort of neglection, some sort of unawareness, some sort of uneducation. So that's how you get this thing. Enteral feeding with the formula and then sepsis. How do you go? This is basically age of 2 to 3 weeks. So it's just the baby is born or maybe the firstborn baby and now is presenting. So first, it's also common in firstborn baby. Then distended abdomen and diminished bowel sounds and then feeding intolerance, increased level of the gastric aspirate or vomitus. Then frank or the occult blood in the stool, signs of the bowel preparation like sepsis, shock, peritonitis, DIC. What do you do X-ray and what are we looking for pneumatosis and intestinalis? That's why I'm saying you have to see the picture of abdominal X-ray. How does it look like? Very, very, very important. And free air, fixed loops, eyelets, thickened bowel walls, and then portal venous gases. I know this kind of stupid thing comes into my mind sometimes. Not sure you will be lucky one or not, but sometimes they give you an X-ray and highlight something and ask you, what is this one? Maybe like, let me show you what I'm talking about. So let's go here. Okay. So we're talking here is NEC. Okay. So let's suppose if they're talking about this one, like an X-ray, okay, and then they highlight this line with like three and can ask you, what is this? Okay, or something like this. Like you can see this is air fluid level, this is what they are like, this is the upper abdomen, and this is the one they're talking about. So they can give you a picture like and ask you three, what is this? Okay, so if you can see it here, so like look for something that can accurately make sense to you. So here this is basically air in the diaphragm, air in the portal tract, then this is distended bowel loop, and this is then intramural air. So this is what they are talking about. So they can give you this line and write down three here and then ask you what is this three. Okay, by giving you a whole scenario, be like whatever this is. Now don't have to make a diagnosis, but you have to tell what did you see in the X-ray. I know this is kind of stupid, but I'm telling you, you never know, you will be getting that one too. Okay. So CBC, ABGs, lactate, blood culture, electrolytes, then low WBC is low platelets, hyponatremia, acidosis, hypoxia, and hypercapnia. What do you do? NPO, vigorous IV fluids, decompression with NG tubes, sportive TPN, antibiotics, and then going for the abdominal X-ray to check for the early perforation.